Yan, okay. So for all of you na nandito, kindly rename yourselves kung hindi pa kayo nakakapag-rename. And today is February 12 at 10 a.m. Di na na-adjust yung editing. Alright, so a few more days. Valentine's na. Ano ba yan? So before we start, let us put ourselves in the presence of the Lord. Kindly join me for a short prayer. Lord, true source of light and wisdom, lofty origin of all beings, graciously let a ray of your brilliance penetrate into the darkness of my understanding, and take from me the double darkness in which I have been born, an obscurity of both sin and ignorance. Give me a sharp sense of understanding, a retentive memory, and the ability to grasp things fundamentally correctly. Grant me the talent of being exact in my explanations and the ability to express myself with thoroughness and charm. Point out the beginning, direct its progress, and help in its completion. You may ask for your personal intentions, and may we also pray for our brothers and sisters that are in most need of the Lord's mercy, especially those that are affected by earthquakes and other, um, disasters. All this we ask in Jesus' name. Amen. Okay, so a few rules of love and respect. I will be the host of this teleconference. Please have your audio on mute. You may, of course, unmute if tinatanong kayo ni Doc, ganyan, or to give feedback. Any video recording, screen shooting, or screen recording of our program, any part is strictly prohibited, okay? So kung meron kayong kakilala na nagbebenta ng handouts, ganyan, or whatever, you can tell your mother this. And also, proper decorum at all times. If you have a concern, message me, Doc Nina, Doc Vicky, Doc Ian, sa Messenger or sa Viber. Okay, if it's urgent, call us. If you want to share suggestions, recommendations, message us. For academic-related concerns, ito yung sa mga handout, questions sa Quizmaster, ganyan. Message nyo si Doc Brody sa messenger niya. Just pakilala lang kayo because, we have a lot of students. And of course, always wear that smile and be happy. Okay, so 32 days before the first day of your board exam. So dapat by 30 days, tapos nyo na all 12 subjects basahin, all 12 videos, all 12 handouts. Important yan, guys. You should be able to finish all the 12 subjects before the first day of your board exam. Right, so for our Pathology Quizmaster 2, we have Dr. Christian Jarrell Cosme. He's a graduate from the University of Santo Tomas, October 2022, first-year pathology resident from the Philippine General Hospital, magna cum laude, BS MedTech sa UST, magna cum laude, Doctor of Medicine, UST, and October 2022, top 9. Ayan. So, kung may mga questions kayo, okay, tanong nyo lang kay Doc Cosme. Hi, Doc!
Hi po. Good morning po, ma'am. Good morning po, mga viewers. So, let's start. Mag-start na po, ma'am.
Yes, Doc, go.
Okay po.
Doc, naka-presenter view ka. Ay,
Yes,
naka.
Ayan po, okay na po. Okay, let's begin. Number 1.
Doc, basahin mo yung question.
Okay po. So, which of the following cells release histamine during acute inflammation? A. Platelets, B. Neutrophils, C. Lymphocytes, D. Eosinophils.
So you will have 30 seconds to answer. Time's up.
Okay, so majority of you answered letter D, eosinophils. So the question seems basic, diba? It's very simple. It's very direct. And most of the questions in the boards ay ganito talaga siya. But the problem is, hindi mo maalala yung sagot or di mo talaga alam. Naalala ko to, nasa first page to ng questionnaire ko. And last ko siyang sinagutan. So again, which of the following cells release histamine daw during acute inflammation? So isipin ko dito, di ba, ay histamine. So baka allergy. So baka eosinophils. So the correct answer is platelets. Well, so this table from Robbins show the principal mediators of inflammation. Unang-una dyan, di ba, histamine. So you would see histamine sa mast cells, also in basophils, and also sa platelets. They mediate vasodilation, di ba? Increase vascular permeability. Other mediators of inflammation, nandyan yung prostaglandin. And all of them cause vasodilation and also pain and fever. So, ano ang type of prostaglandin that mediates fever? Diba? PGE2 or prostaglandin E2. So you can check this table from Robbins kasi there are some information din that I easily forget. Ang ginagawa ko is binabasa ko sila day before the board exam or hours before the board exam. Diba? So let's answer some questions. So, vasoactive amine causing vasoconstriction. Answer, serotonin, diba? Serotonin nga daw. Arachidonic acid metabolite causing vasoconstriction and platelet aggregation. Lumabas to sa boards, the answer is thromboxane A2. Next, arachidonic metabolite causing vasodilation and inhibits platelet aggregation. Isa lang sagot dito, prostacyclin or PGI2. Ito, next question. Lumabas din to sa boards. Complement deficiency associated with Neisseria infections. Answer, membrane attack complex or C5b to C9. Ito, here's a table showing the arachidonic metabolites that play a role in inflammation. Again, di ba, prostaglandins, they all cause vasodilation. Yung vasoconstrictors mo, this include thromboxane and leukotriene C, D, and E. Remember, C, D, and E. The leukotrienes that increase vascular permeability, pareho lang din sa vasoconstrictors. However, may leukotriene na nagkakos ng chemotaxis. Isa lang yan, leukotriene B4. Ito naman, the table on the right, shows some inflammatory diseases with the cells and molecules involved sa injury. Lumabas sa boards, which of the following does not involve neutrophils? A. ARDS, B. Abscess, C. Glomerulonephritis, and D. Septic shock. So from this table, you would see, diba, septic shock, ang involved na molecule ay cytokines, not neutrophils. So here naman, diagram illustrates the steps involved in leukocyte recruitment. First step, margination. So there's peripheral positioning of the WBCs along the endothelium. That's why, diba, in some infections, you would see that in your WBC, it's decreased instead of increased, diba? Kasi yung majority of our WBCs are located peripherally. Nasa endothelium pa lang sila. Next step, rolling. So there's transient binding and detachment of leukocytes sa endothelium. So gumugulong pa lang siya. So ano yung mga mediators yan, di ba? Sialyl-Lewis and the selectins. Next, after transient binding, you would see tight binding. So there's firm adhesion of leukocytes to the endothelium. And mediated naman sila by alpha-1 and the ICAM. Next step, diapedesis. So the WBCs would cross the endothelium at this point, di ba? Tatawid na sila. There's transmigration. And what's the site of diapedesis, di ba? The post-capillary venules. And lastly, the WBC would move towards a chemotactic signal. Di ba? The most common exogenous product is N-formylmethionine. And endogenously, ang chemotactic signals mo ay ang IL-8, 6,5A, and leukotriene B4. Okay, next question.
Mm. 5 seconds.
Okay, so majority answered letter B, endocardium. So this question also came out in the boards. Personally, ko talaga alam yung sagot, but you actually get some clues from the question. So you have carcinoid syndrome daw, di ba? It's caused usually by a carcinoid tumor. Saan ba commonly located ang carcinoid tumors? Di ba sa GI tract? And all substances in the GI tract are absorbed by the venous system, which drains ultimately into the right side of the heart. So, di ba, all of the following cardiac structures are primarily affected in carcinoid syndrome except letter A, mitral valve, di ba, left side of the heart to, and the cardium located both in the left and the right. Letter C, tricuspid valve, di ba, located yan sa right side of the heart, as well as pulmonic valve. So the answer is letter A, mitral valve. Okay. So carcinoid syndrome, it's a constellation, di ba, of symptoms that include flushing, hypotension, abdominal pain or diarrhea, bronchospasm, and right-sided valvular heart disease. Remember this, right-sided valvular heart disease. In the boards, they ask also, which of the following symptoms are not included in carcinoid syndrome? May choice doon, hypertension ba? Pero ang tamang sagot dapat ay hypotension. So here, the diagram again shows the pathophysiology of carcinoid heart disease. So diba, there's a carcinoid tumor in the intestines, particularly most commonly located sa small intestine. So it would drain into the liver via the portal vein, and it would drain into the vena cava and would affect primarily the right side of the heart. It less likely the left side of the heart would be involved kasi the serotonin or the vasoactive substances are deactivated by the lung, particularly the MAO and the aldehyde dehydrogenase. However, left-sided carcinoid heart disease may occur, such as in lung carcinoid or bronchopulmonary carcinoid, or if there's a connection between the right and left heart via a shunt, and also if there's high burden of disease. Okay, next, let's answer some questions. Bioactive compounds that correlate with the severity of cardiac lesion sa carcinoid heart disease. The answer, serotonin and 5-HIAA or 5-hydroxyindole acetic acid, which is a metabolite of serotonin. Next, typical cardiac lesion in carcinoid heart disease, diba? Tricuspid insufficiency and pulmonary stenosis. Most common tumor of the appendix. Surprisingly, hindi siya adenocarcinoma. The answer is carcinoid tumor. Next, lung tumor producing the so-called collar button lesion. Answer, carcinoid tumor rin. Since we're talking about tumors na rin, which is the most common primary tumor of the adult heart? Answer, myxoma. Next, the most common primary tumor of the pediatric heart. Answer is rhabdomyoma. So we are in cardiac pathology. Here's a table I want to share. It's very high yield, which shows the morphologic changes post myocardial infarction. So it contains a lot of information, di ba? Medyo parang hirap i-memorize. Maybe you have memorized na this, but you may have better ways on how to memorize the table. But personally, I take in mind the sequence of changes that occur following an injury or an inflammation. First, think of 4 Rs. In less than 4 hours, there are no gross changes. There are no light microscopy changes. However, always as during med school, diba, you might see myocardial waviness. In the next 4 hours to 3 days, in acute ischemic infarct, you would see, diba, coagulative necrosis. And what cell yung unang darating kapag acute inflammation or injury, diba? So neutrophils. Next naman, very important as well, days 3 to 7. So there's the disintegration of the dead myofibers caused by the phagocytosis of the macrophages. So at this time, the ventricular wall is at its weakest. So this time, the heart is most prone to myocardial rupture. Remember, 3 to 7 days, myocardial rupture. Next, after a few days, di ba, normally if may injury ka, gagaling siya. So at days 7 to 14 or 1 to 2 weeks, you would expect granulation tissue already. So there's healing. Next naman, and lastly, 2 weeks and beyond, you expect collagen deposition. So meron na siyang scarring. Okay? Next question. A 72-year-old woman failed to get a flu shot. She became ill as many people in her community did. She had fever, non-productive cough, mild chest pain, myalgias, headache. What chest radiograph finding is most likely present in this patient?
Five seconds.
Okay, so majority of you answered letter B. So from this question, lumabas rin to sa board exam. A 72-year-old woman failed to get a flu shot. So flu, di ba? It's caused by influenza virus. So she became ill as many people in her community did. So it's very typical of viral infection kasi there's clustering of symptoms. Next, she had fever, non-productive cough, mild chest pain. So this is very typical, diba, of pneumonia. However, take note, there's non-productive cough. So it denotes a viral infection. Ang tanong, what X-ray finding daw ang makita sa patient na ito? So letter A, marked hilar lymphadenopathy. B, bilateral interstitial infiltrates. C, left upper lobe consolidation. Or D, extensive pleural thickening. So the correct answer is bilateral interstitial infiltrates. Yung letter A, marked hilar lymphadenopathy, nakita siya sa granulomatous infections such as in tuberculosis or some fungal infections. Letter C, lobar consolidation, di ba? Characteristic to ng bacterial pneumonia. And tama ang sagot niyo lahat, bilateral interstitial infiltrates. So bakit ganun yung lumalabas sa X-ray, di ba? So, on X-ray, you would see interstitial infiltrates. Kasi on microscopy, the inflammation is located in the interstitium or in the alveolar septa. And the infiltrates, alam nyo na to, mononuclear siya, particularly lymphocytes. Next, bacterial pneumonia naman, di ba? The inflammation is located intra-alveolar or located in the alveoli. So there's exudates, di ba, within the alveoli. The infiltrates in bacterial pneumonia, neutrophils. This explains why, di ba, kapag bacterial pneumonia, productive cough ka, kasi yung exudates mo nasa loob ng alveoli. So here's the two anatomic distribution or patterns kapag may bacterial pneumonia ka. First, di ba, bronchopneumonia, there's patchy consolidation, kalat-kalat siya. Yung isa naman, lobar pneumonia, it involves one lobe. So here's, in lobar pneumonia, there are 4 stages of inflammatory response. Una, congestion, di ba? Red hepatization, gray hepatization, then resolution. Medyo madali siyang i-memorize, pero pag tinanong yung microscopy, medyo nakalito. Una, yung congestion, di ba? From the name itself, there's congested vessels, so you would see engorged capillaries. At this point, wala ka pang exudates. Next naman, red hepatization. There's already exudation and meron ka ng RBCs, kaya color red na siya. Red hepatization. Next, gray hepatization. Meron ka pa ring exudates but nag-disintegrate na yung RBCs mo. Wala ng RBC, so color gray na siya. And lastly, wala nang exudates or resolution. And in healing, you would expect, diba, there are macrophages and there are fibroblasts. Okay, next, the most common cause of community-acquired pneumonia. Answer, strep pneumoniae. Most common bacterial cause of acute exacerbation of COPD. So this is based on Robbins, no? The answer is H. influenzae. Next, important cause of secondary bacterial pneumonia following viral infections associated with IV drug users, lung abscesses, and empyema. Alam niyo na to? Staphylococcus aureus. Next, the most frequent cause of gram-negative bacterial pneumonia. Answer, not E. coli, it's Klebsiella pneumoniae. Next, associated with cystic fibrosis and immunocompromised and neutropenic patients. Sagot ay Pseudomonas aeruginosa. Okay, next. So a 48-year-old female presented with hydrothorax and ascites. Transvaginal sonography showed adnexal mass. Which benign ovarian neoplasm is most often associated with this syndrome? A. mucinous tumor, B. corpus luteum cyst, C. teratoma, D. fibroma.
Second.
Okay, so majority of you answered letter A, mucinous tumor. So, let's first identify anong syndrome yung nire-refer sa question. Let's identify the salient features. There's hydrothorax, there's ascites, and merong adnexal mass daw. So, anong syndrome to? Diba? Meigs syndrome. Ang tanong, which tumor daw yung most commonly associated dito? The answer is fibroma. So here's Meigs syndrome. This is the triad of Meigs syndrome. Here's fibroma, ascites, and pleural effusion. And the tumor irritates the peritoneal and pleural surfaces, kaya ka may fluid build-up. So, di ba, ang Meigs syndrome, may benign ovarian tumor ka raw. Some literature say na benign ovarian tumor, pero yung iba, fibroma lang. Kasi in 90% of the cases, fibroma yung benign ovarian tumor sa Meigs syndrome. Next naman, you have pseudo-Meigs syndrome. It's any tumor located in the pelvis or ovary. So pwedeng leiomyoma, pwedeng leiomyosarcoma, or any malignant ovarian neoplasm. Next naman ay ang pseudo-Meigs syndrome, also called as Tijalma syndrome. Instead of ovarian tumors or pelvic tumors, the ones causing the pleural effusion and ascites is SLE. So here's the WHO classification of ovarian tumors. Diba? May surface epithelial, sex cord stromal, germ cell, and metastatic. So in surface epithelial stromal, una dyan yung serous, diba? It's the most common malignant epithelial tumor. It's the most common malignant ovarian tumor rin overall. Next, mucinous lumabas sa boards. It is the largest ovarian tumor. It can reach up to 25 kilograms. Under surface epithelial, you have endometrioid, ear cell, transitional cell, or other term, diba? Brenner's tumor. It's called transitional cell because it resembles that of the urothelium, of the urinary bladder. Next naman yung sex cord stromal, you have here granulosa cell tumor, which is the most common malignant sex cord stromal tumor. Included din dito fibromas, fibrothecomas, and Sertoli-Leydig cell tumors. Next classification, the germ cell tumors. Teratoma, it is the most common germ cell tumor. Included din dito monodermal, dysgerminoma, which is the most common malignant germ cell tumor. Ano nga yung homolog ng dysgerminoma sa male genitalia? It's the seminoma. Next naman, yolk sac tumor. It's the most common GCT in children. Included din sa germ cell yung mixed and choriocarcinoma. And last classification is metastatic. And the most common metastatic tumors ay yung Mullerian origin. Ano-ano ba ito? Yan yung fallopian tubes, uterus, and cervix. So here, metastatic GI carcinoma to the ovaries with signet ring appearance. The answer? Krakenberg tumor, di ba? They are often bilateral then. Next, also known as endodermal sinus tumor. And there's the presence of Schiller-Duval bodies. Yung Schiller-Duval bodies, di ba, para siyang glomerulus, mayroong tumor cells that surround a central lumen, which is a blood vessel. Ang answer? Yolk sac tumor. Next, this tumor causes hyperestrogenism. So pwede mag-present ng AUB yung patient, proliferative breast cancer, or endometrial CA or hyperplasia. And pathognomonic sa disease na to, called Exner bodies. So para siyang gland-like structures with acidophilic material sa gitna niya. So, ang answer? Granulosa cell tumors. Ito naman, this tumor causes masculinization or defeminization. So isipin mo anong cells ba ang magkakos ng secretion ng testosterone. So you would think of Leydig cells, di ba? So ang answer, Sertoli-Leydig cell tumor. This tumor is composed of thyroid tissue, so they may secrete thyroid hormones causing hyperthyroidism. Answer? Struma ovary. Ito naman, this ovarian tumor is associated with pseudomyxoma peritonei. Sagot? Mucinous tumor. Anong other organ nga yung nagkakos ng pseudomyxoma peritonei? The appendix. So here are some serum markers and their corresponding tumors. CA125 CEA, makita lang siya sa epithelial tumors. LDH, dysgerminoma. HCG, sa choriocarcinoma. Kasi diba yung chorion nagpaproduce ng beta HCG. AFP or alpha fetoprotein. You would see this in yolk sac tumor. Okay? Next. Which of the following features differentiate Crohn's from ulcerative colitis? Letter A, marked pseudopolyp formation, increased risk of disease with appendectomy, inflammation is limited to the mucosa, and letter D may lead to toxic megacolon.
Five seconds.
Okay, so majority answered letter C. Inflammation is limited in the mucosa. So, the correct answer is letter B, increased risk of disease with appendectomy. So, diba yung topic na to, lalabas to sa boards for sure. Either in pathology, IM, or surgery, laging may Crohn's versus ulcerative colitis. So, diba, ang daming features that would differentiate them. Bowel regions sa Crohn's, ileum or colon, diba? Pero in general, it may affect all parts of the GI tract, including the mouth. Ulcerative colitis, diba? Colon lang siya. From the name itself, colitis, colon. Heterogeneous distribution, when you hear the skip lesions or when you read this, you would always automatically answer Crohn's disease. Pag ulcerative colitis, diffuse yung lesions niya. Again, ang daming features, ang daming i-memorize, di ba? Pero for me, paano ko siya memorize? Lahat ng words, lahat ng kakaiba, lahat ng peculiar, nasa Crohn's, di ba? Like stricture, sa Crohn's yan. Wall appearance, mas makapal sa Crohn's. Inflammation, transmural kapag Crohn's. Kapag ulcers, mas deep sa Crohn's. Lymphoid reaction, mas marked sa Crohn's. Fibrosis sa Crohn's din. Serositis sa Crohn's. Granulomas, remember this, lumabas rin sa boards. There's the presence of granulomas. Fistulas, Crohn's. Perianal fistula sa Crohn's din. Malabsorption, Crohn's. And recurrence after surgery sa Crohn's. However, there are exceptions. Tatlo yan. Pseudopolyp formation, mas marked sa ulcerative colitis. Also, malignant potential and toxic megacolon. Again, pseudopolyp formation, malignant potential, and toxic megacolon. Also, remember this, lumabas rin to sa boards. The role of smoking and appendectomy. Sa role of smoking in Crohn's disease, it's a strong risk factor. In ulcerative colitis, it partially relieves the symptoms. Appendectomy, it increases the risk of Crohn's disease, but it is protective sa ulcerative colitis. Okay? Let's answer some questions ulit. Earliest lesion of Crohn's disease. Ito, nakabold to sa Robbins. Nandun din siya sa table. So the answer, aphthous ulcer. Ito, cobblestone appearance of the intestinal mucosa. Medyo buzzword, di ba? So ang answer, Crohn's disease. Antibodies associated with Crohn's disease, anti-Saccharomyces cerevisiae. Next, antibodies associated with ulcerative colitis. Answer, P-ANCA, or formerly known as MPO-ANCA. Since we're in the topic of ANCAs na rin, which small vessel vasculitides are associated with P-ANCA? Dalawa to, di ba? Microscopic polyangiitis and Sjögren's syndrome. Next, small vessel vasculitis associated with C-ANCA naman. Isa lang to, ang answer, granulomatosis with polyangiitis or Wegener's granulomatosis. Okay? Next question. Which of the following immunologic diseases is classified as antibody-mediated hypersensitivity reaction? A. Post-strep GN. B. Rheumatoid arthritis. C. Rheumatic fever or RHD. D. Anaphylaxis.
Five seconds.
Okay, so most of you, 34% answered letter A, PSGN. But actually, the answer is letter C, rheumatic fever or RHD. Medyo nakakalito, di ba? Letter A, type 3, PSGN yan. Letter B, RA, type 4. And of course, type D, alam niyo lahat. Type 1, anaphylaxis. So here's how I remember the types of hypersensitivity reactions by ABCD, di ba? Type 1, IgE mediated. So letter A, anaphylactic and atopic. Type 2, letter B, it's antibody mediated. Type 3, letter C, it's immune complex mediated. Type 4, cell mediated yan. So it's letter D, delayed. Kasi diba, they might not ask the numbers like type 1, 2, 3. They may ask the mechanism. Pwedeng, diba? IgE-mediated, antibody-mediated, etc. So here's a table that show the disease examples that fall under each type of hypersensitivity. Type 1, again, anaphylaxis, diba? Asthma, hay fever. Hay fever, also known as allergic rhinitis. Also food allergies. So I want you to remember here, yung rheumatic fever or RHD, type 2 siya, hindi siya type 3. PSGN, type 3 siya, hindi siya type 2. Also, type 4, yan, nandiyan yung contact dermatitis, RA, type 1 DM, psoriasis. Important to take note here that the tuberculin skin test or the PPD is a type 4 hypersensitivity reaction. Okay? So, di ba, in strep infection, you get exposed to the beta hemolytic strep. So the body mounts an immune response against the antigen, which cross-reacts with the antigen sa heart. Kaya nga ang hallmark of pathogenesis ng RF and RHD ay molecular mimicry. Diba? Yung immune responses against the microbial antigens may result in the activation of self-reactive lymphocytes. So kagaya ng antigens ng strep, yung antigen sa heart. So, which streptococcal antigen cross-reacts with cardiac myosin? Ito, micro crossover. Answer? M protein. Ito naman, pathognomonic of RHD. Granulomatous lesions in RHD composed of foci of T lymphocytes, plasma cells, and macrophages. The answer is Ascough bodies. Next, macrophages with abundant cytoplasm with central round to ovoid nuclei and slender wavy chromatin, diba? Kaya tinawag silang caterpillar cells. The answer? Anichko cells. Kasi diba para kang may wavy ribbon dyan, parang caterpillar. Okay, next question. Which of the following conditions is not associated with MEN1 syndrome? A. Pancreatic tumors. B. Pheochromocytoma. C. Parathyroid hyperplasia. D. Pituitary adenoma.
Five seconds.
Okay, 37% of you answered letter B, pheochromocytoma. Tamang sagot? Letter B, pheochromocytoma. So, di ba, there are 3 subtypes ng multiple endocrine neoplasia syndrome. MEN1A, MEN1, MEN2, and MEN2B. In MEN1A, other term dito, Wermer syndrome, di ba? So, you would see here, tatlong P's. Ang mnemonic nila dito, di ba, Papa P. Parathyroid hyperplasia, pancreatic tumor, and pituitary adenoma. Parathyroid hyperplasia, yan yung most common manifestation ng MEN1. Pancreatic tumor, yung most commonly secreted product is pancreatic polypeptide. In pituitary adenoma, the most common anterior pituitary tumor that you would see is the prolactinoma. Next naman, MEN2A, also known as sickle syndrome. Dito meron ka pa ring parathyroid hyperplasia. However, meron ka na dito medullary thyroid carcinoma. It's almost present in 100% of patients. And also, pheochromocytoma. Next ay MEN2B, multiple mucosal neuroma syndrome. Dito meron kang Marfanoid body habitus, medullary thyroid carcinoma rin. However, you would see here mucosal neuromas. And also, pheochromocytomas. Okay? In pheochromocytoma, di ba, meron tayong rule of tens. 10% are extraadrenal, 10% are bilateral, 10% are malignant, and 10% are not associated with hypertension. Meron additional pero hindi siya 10%, 25% have germline mutations or genetic mutations. What's the only reliable criterion for malignancy sa pheochromocytoma? The answer is metastasis. Ito naman, most common cause of primary hyperparathyroidism. The answer is sporadic parathyroid adenoma. Hindi parathyroid hyperplasia. Next, hyperparathyroidism is what? Metastatic calcification ba siya or dystrophic calcification? Ang answer, metastatic calcification kasi 'di ba if you could recall this sa intro ng pathology 'di ba? Metastatic calcification, there's increased serum calcium levels. As compared sa dystrophic calcification, you would see this sa injured tissues 'di ba? Like atherosclerosis. Okay? Next question. This chronic inflammatory disease produces a focus of activated macrophages rimmed by fibroblasts, histiocytes, and lymphocytes, with a central zone of amorphous eosinophilic granular debris and complete loss of cellular details. Okay? Okay, most of you, 55% answered letter D. So sa question, di ba, yung first part, this chronic inflammatory disease produces a focus of activated macrophages daw with fibroblasts, histiocytes, and lymphocytes. Anong pinapertain dito? So you have a granuloma. And sa gitna daw ng granuloma, meron kang zone of amorphous eosinophilic granular debris and complete loss of cellular details. So there's necrosis. What type of necrosis yung associated with TB? Diba? Causation necrosis. So answer is letter D, tuberculosis. Okay, so here's a perfect picture of what a granuloma looks like. So you would have lymphocytes, the Langerhans giant cell. Don't get confused with Langerhans cell na located sa skin, di ba? Yun yung resident macrophages located sa skin. And the hallmark of granuloma, not Langerhans giant cell, it is the epithelioid cells. Langerhans giant cell, nag-fuse yan na epithelioid cells. And also very characteristic and peculiar of TB granuloma, it's the presence of caseous necrosis. Okay? So here are some diseases with granulomatous inflammation. Una dyan, di ba, tuberculosis. Characteristic, cacheating granuloma. Also leprosy, there's granuloma but it's non-cacheating. Also syphilis, di ba? Specifically sa gumas. Anong stage ng syphilis nakita yung gumas? Sa tertiary syphilis. Also, ask in the boards, anong histology raw yung nakita kapag syphilis? Like kung inaalala dito is yung plasma cell or lymphoplasmacytic infiltrates. Next, cat scratch disease. Remember here, stellate granuloma. Sarcoidosis also produces non-cacheating granuloma. Again, as what we mentioned earlier, diba? Crohn's disease, there's granulomas as well, but it's non-cacheating. Cacheating lang, tuberculosis. So here are some pictures that I got from my first autopsy. I just wanted to share this. So this is a case of a 34-year-old male. So you would see sa taas ng lung, diba? There's a cavitation. And also sa cut section, you would see that there are cheese-like nodules, there are cheese-like appearances, areas of necrosis, very typical of TB. And on microscopy, as expected, you would see chronic granulomatous inflammation. Okay? So let's recall the types of necrosis. Una, caseous necrosis. Again, nakita siya sa TB, nocardia, and systemic fungi infection, such as histoplasmosis. And in histopath, you would see granuloma, again with a very typical cheese-like gross appearance. Next ay ang coagulative necrosis. You would see this in ischemia or infarcts in most tissues except the brain. Here, you would see increased eosinophilia or mas pink yung cells. And you would also see ghost cells. Parang ito, sa kidneys, di ba? Parang wala nang nuclei lahat. Preserve lang yung architecture. There are outlines ng cells. Parang ghost, di ba? That's why the term is ghost cells. Next, liquefactive necrosis. You will see this in bacterial abscesses and CNS infarcts. For some unknown reasons, yung brain talaga, liquefactive yung necrosis niya. Just remember that. And on histopath, you would see cellular debris, neutrophils, there are cystic spaces or cavitations. Okay, next naman, fat necrosis. This could be enzymatic or non-enzymatic. Sa enzymatic, di ba, you have acute pancreatitis. There's release of lipase. Traumatic naman, like in breast injury. So you would see fat saponification and chalky deposits on gross. Kasi nag-combine yung fatty acids mo with calcium. And on H&E, you would see that the calcifications would stain dark blue. Next type of necrosis is fibrinoid. You will see this in immune vasculitis, di ba? Mga SLE, polyarteritis nodosa, also in hypertension, preeclampsia rin. And you would see the eosinophilic layer of proteinaceous material around the vessel wall. It's called fibrinoid kasi hindi siya totoong fibrin. Fibrinoid lang. It's fibrin-like. And also, the last type of necrosis, you would see this, yung gangrenous, di ba? Sa distal extremity or GI tract. In the dry type of gangrenous necrosis, it is seen in ischemia. Kapag wet, may superinfection. Pag dry, coagulative necrosis. Kapag wet, coagulative siya but may superimposed liquefactive necrosis. Okay, next question. Which intracranial tumor is associated with calcifications in 90% of its cases? A. Oligodendroglioma, B. ependymoma, C. Glioblastoma, D. medulloblastoma.
Five seconds.
Okay, so majority of you answered letter D. Ay, same pala, C and D, 33%. Glioblastoma and medulloblastoma. Okay. So sa boards lumabas ng question na to, which intracranial tumor is associated with calcifications lang? Di ba parang sobrang vague niya, parang lahat pwede mag-calcify. But actually, there's one tumor here na may characteristic calcification siya. And the answer is oligodendroglioma. So, di ba? Oligodendroglioma, from the name itself, it resembles oligodendrocytes. And remember this, the genetic mutations, IDH1 and 1P, 19Q, 19Q, co-deletion. So, dapat parehong may deletion yung 1P and 19Q. And on gross examination, makita mo, gelatinous, gray masses, often with cysts, focal hemorrhage, and calcification. Pwedeng microscopic foci lang siya, or pwedeng massive depositions. Anong buzzword pag oligodendroglioma, di ba? Chicken wire appearance. Yan yung delicate anastomosis of capillaries. Parang chicken wire. Also, di ba, saan galing ang chicken? Sa egg. Yan din yung fried egg appearance. Di ba? Parang may yolk ka rito, tas yan yung egg white. Okay? Also, again, classifications, remember, sa oligodendroglioma. Okay? Most common glial tumor in childhood. Meron siyang Rosenthal fibers. Itong eosinophilic corkscrew substances or features here, di ba? Para siyang corkscrew. Sagot dito, pilocytic astrocytoma. Next, most common and most malignant glial tumor. And here you would see serpentine pattern of pseudo-palisading necrosis, di ba? Para siyang snake na magka-connect. May palisading ng tumor cells around the area of necrosis. The answer? Glioblastoma multiforme. Okay? Next, hyperostotic changes in adjacent bone. Meron daw siyang whorled pattern. Meron ding Samoma bodies. Samoma bodies, what type of calcification? Dystrophic or metastatic? Samoma bodies, dystrophic calcification din yan. Okay? Sagot dito, meningioma. So here are the rosettes in pathology. Diba? Ang daming rosettes, nakalito. Homer Wright rosette. Here you would see tumor cells around a neuropil. Nakita to di lang sa intracranial tumor, medulloblastoma, pati sa neuroblastoma. Next, perivascular pseudorosette. It's called pseudorosette. It's a fake rosette kasi may tumor cells around a blood vessel. The answer is ependymoma. Ito, Flexner-Winter-Steiner rosette. Hindi siya nakita sa brain. It's a tumor located outside the brain. So here, the tumor cells are around cytoplasmic processes. So, nakita to sa retinoblastoma. Okay? Last question. The distinctive feature of this lymphoneoplasm is the presence of large cells that are either multinucleated or have bilobed nucleus with prominent eosinophilic inclusion-like nuclei resembling an owl's eye appearance. A. Burkitt, B. Follicular, C. Diffuse large B-cell lymphoma, or D. Hodgkin's lymphoma. Okay, so majority of you answered letter D, Hodgkin's lymphoma. Okay, ano bang tawag sa cells na to, di ba? Diba? Reed-Sternberg cells. So it's pathognomonic of Hodgkin's lymphoma. Burkitt, non-Hodgkin yan. Follicular, non-Hodgkin din. Also, DLBCL, non-Hodgkin. So, the distinctive morphologic feature ng Hodgkin's daw, Reed-Sternberg cells. And it's infected with EBV in 70% of cases. You could see here sa picture, di ba, parang owl's eye. Anong virus nga yung may owl's eye inclusions din? CMV. So there are 5 subtypes ng classical Hodgkin: nodular sclerosis, which is the most common; mixed cellularity; lymphocyte rich, which is it has the best prognosis; lymphocyte depleted, it's the least common, but it has the worst prognosis, and it's associated with people living with HIV. And lastly, nodular lymphocyte predominant. Okay, ito yung differentiating factors between Hodgkin and non-Hodgkin. Kapag Hodgkin, it's often localized to a single axial group of nodes. Kapag non-Hodgkin, multiple yan, peripheral. Orderly spread then kapag Hodgkin, it's by contiguity. And there's rare involvement of the mesenteric nodes and Waldeyr's ring. And extranodal presentation is rare with Hodgkin's lymphoma. Okay, ito. Numerous pale, tingible body macrophages producing a starry sky appearance. EBV associated, tapos may MYC gene translocation ka. Ito, buzzword. Nilito rin ako rito, di ko alam kung Burkitt ba or Hodgkin's. Burkitt lymphoma yung may starry sky. Okay? Most common NHL, diffuse large B-cell lymphoma. Most common indolent lymphoma of adults, follicular lymphoma. So, non-Hodgkin lymphoma that arises from sites of chronic inflammation like H. pylori gastritis sa stomach or Hashimoto thyroiditis. So, ang answer, marginal zone lymphoma. Okay, so here you would see, di ba, there's an aspirate of cells with perinuclear halo, parang may coughing ka rito. It's plasma cells, di ba? And you would see punch out bone lesions here sa skull. Okay? The disease entity is multiple myeloma. Naalala niyo yung mnemonic na CRAB, di ba? Letter C for calcium elevation, R, renal involvement, A for anemia, B for bone lytic lesions. What are the light chains excreted sa urine ng multiple myeloma? It's the Benz-Jones proteins. Okay? Most common immunoglobulin elevated kapag multiple myeloma. Hindi siya IgM, but IgG. Okay? So here are some of the inclusions sa nakita sa multiple myeloma. Una, yung fiery red cytoplasm. Diba? Yan yung flame cells, para siyang flame. Okay, next, multiple grape-like inclusions. Ito. Answer, what cells? Next, globular cytoplasmic inclusions. The answer, Russell bodies. Next, globular nuclear inclusions. Ayan, nasa loob siya ng nucleus, so the Dutcher bodies. So paano ko siya naaalala kapag cytoplasmic, Russell letter R. Di ba pag RNA, nasa cytoplasm. Kapag nuclear naman, the Dutcher bodies, parang DNA, located inside the nucleus. Okay, that ends my presentation, but I want to share this quote. Shoot for the moon, even if you miss, you'll land among the stars. Diba? Always work hard kasi hard work does really pay off. And always remember, kasi may times, diba, na parang ayaw mo na mag-aral, sobrang pagod na. Minsan parang wala ka pang 10 pages per day. But remember always, bakit mo ginagawa to? Anong purpose mo? And para kanina to? And like ko rin iniisip noon na itong hard work ko, yung pinaghihirapan ko, i-bless ako ni Lord after nito. So ayun, malapit na yung boards. Malapit na. Good luck everyone. Thank you.
Thank you so much, Doc. Thank you, thank you.
Thank you so much, Christian.
Oh, thank you.
Lala, kumusta?
Ay, Doc, okay yan.
My thoughts about Pato. Pato, honestly guys, ito yung kinakatakutan kong subject for everyone. Dahil based on what has happened doon sa last October batch, hindi siya pinagkukuhanan diretso sa Robins. Or may pag kinukuha man nila sa Robins yung questions, yung medyo trivial portions ng Robins yung kinukuha. So it's we've discussed this with Kevin Elomina, your main teacher here. I'm going to have him talk to you again before your boards, after your finals, but before your boards. Mga final tactics and strategies for Pato. Okay? But personally, my advice, Doc, magpapatoma ba kami? Okay? Honestly, ang patoma, best yan when you have it, when you watch it during clerkship or internship. Not really for the boards, in my opinion. Okay? Even if you've watched that, even if we base our handles on patoma, may magiging struggle for the students dahil ang questions are based not just on pato references but also micro, mga kung saang practice tests coming from all over the internet. So best most practical thing to do is really to just focus on as little materials as possible, try to master them, and then pray for the best. So in here, what you really need naman sa buhay talaga is the one based on the Robbins, with some additions from the clinics. So the handout with Dr. Kevin Elomina, plus his lecture video, that's the one that I can really recommend to everyone. You can have the flashcards, the practice test, kahit paano, pumasok yan. But guys, please, okay, do not, hindi siya magiging katulad ng legal med of micro na halos giveaway lang. You're really most probably going to struggle in this subject. Expect that. Okay? Dissociate your feelings about top-notch and about the Pato boards. Hindi kami yung gumawa ng Pato board exams. We're only preparing you as best as we can for something that's very difficult. Okay? Some things lined up also. We're going to have someone who has taken the med boards 3 times before talk to you, give a special talk on tactics, processing of emotions, 1 day before your finals. So this will be on Feb 27. Okay? Papayos yan and then we'll announce kung ano yung time. What else? Coordinate with your mentors, Mother Goose. Okay, especially after the finals. If you're thinking about skipping the March board exams, I would suggest you leave that as a decision only after your finals and in consultation with other people, your mentors, your friends, your family, even me. If you want to talk about it, okay, just message me and I'll gladly call you para mapag-usapan natin. Best pa rin is to take the med boards as soon as you can, close to your internship year. That's your best possible chance. But I do agree, some people, mental health issues, preparation issues, hindi kaya. Okay, so let's tackle it in a professional academic manner. Kung paano ang tactics and strategies pag ganyan. So again, Feb 27, special talk regarding from a testimonial ng previous someone who's taken the med boards 3 times before, past just October 2022, yung pinakahuling med boards lang. Okay, talk ni Dr. Elomina after the finals, but before your med boards, final tactics niya. You'll also have a special lecture with Dr. Ronnie Baticolon for Biochem, 1 day before your med boards, 1 or 2 days before your med boards, ipa-finalize pa rin natin. So para siyang final na tactics for Biochem, your first subject in the med boards, a little bit of pep talk na rin also. So we have a lot planned for you for the next few days. We have an on-site lecture optional. Again, you can take that online or you can take that on-site. I would recommend personally, kung malayo kayo sa Manila, gusto makatipid, doon na lang kayo sa online version. If you're in Metro Manila or you want something different, very close to the med boards, can take and opt for that on-site lecture. So thank you very much. Back to you, Dr. Lala.
Thank you so much, Doc Brody. And thank you everyone for joining us for this Quizmaster session. So, mag-aaral kayo mabuti. Malapit na ang board exam. And see you on the other side. Okay? Thank you everyone. Bye. Happy aral. 32 days to go.